Hello, welcome to our first Lunch and Learn episode in honor of Body Awareness Week from White Pine Center for Healing. My name is Brandis Montgomery, and I'm the clinical director here at White Pine Center. Today, I'm going to be going over what we call Eating Disorders 101. So, just the really basic information that you might need to know or want to know about eating disorders, the three major types. I will also go over a few what I call honorable mentions as far as not being in the DSM, the book that we use to diagnose mental health disorders, but some things to be aware of, along with a few other tidbits to learn about eating disorders or disordered eating. And I'm going to use those terms interchangeably. So, first, I'd just like to start out with a couple of statistics. 42% of girls in the first through third grade claim they want to be thinner. To me, that is a startling statistic about what's happening to our youth. And that's part of White Pine Center's mission is to start this conversation, have this conversation just be open so that we can really tackle disordered eating and what it does to our communities, our families, as well as the individuals who are suffering. Another statistic is 81% of children who are only 10 years old say they are afraid of being fat. Again, another startling number of 81%. 13% of women over the age of 50 have eating disorder symptoms. So that's on the other end of the spectrum when we're considering age. Eating disorders do not, it doesn't matter what age you are, doesn't matter what race, doesn't matter the socioeconomic status. An eating disorder will affect anyone depending on what I call if they have a perfect storm, which I'll go over in a little bit. So some of the eating disorders, the most popular ones, I'll be going over. The first one is anorexia nervosa. It's characterized by a restriction of your food intake, not getting enough to sustain your daily activities, leading to significantly low body weight, along with an intense fear of gaining weight or becoming fat, and a persistent behavior that interferes with weight gain, which usually looks like restriction. Lastly, there's also a distorted view of the body or shape or lack of recognition that there's a seriousness of their current low body weight. It's sort of what I call having eating disorder goggles on. When someone is suffering from disordered eating, it's very difficult for them to see themselves in the truest light, to see their body in the truest light. There are definitely two different types of anorexia. You have the restricting type, which is just simply restricting your food intake on a daily basis or regular basis. And then the other type is binge eating and purge type. So this means there might be different episodes of binge eating and then purging those calories and then longer stints of restriction. But there are a few episodes in there, recurrent episodes of binging and purging. So some of the common signs to look out for when you suspect that someone might be struggling with anorexia, of course, is the dramatic weight loss. Sometimes they wear a lot of layers of clothing to sort of hide their body. They have a preoccupation with food, fat grams, dieting, anything food related. There might be a lot of body checking happening, whether it's in the wrists or the hips, stomach, or thighs. And then some might suffer from having a rigid exercise routine. They might be exercising way more than they should, and at different hours, long intervals, and it doesn't matter the weather or if there's an injury. They feel like they need to engage in exercise to get rid of the calories and to burn fat. So there are many risks and complications involved when someone suffers from anorexia. There are a lot of heart issues that could arise, hormonal imbalance, gastrointestinal complications, and could lead to heart failure, which is, the scary part of anorexia. The next that I'll talk about is bulimia nervosa. So, this one is characterized by eating in a short period of time an amount of food that is larger than what most individuals would eat in a similar period of time. So, that would constitute what a binge would look like. And there's also a sense of lack of control over the eating during that overeating episode. There are recurrent inappropriate compensatory behaviors in order to prevent weight gain. So, what a compensatory behavior is either vomiting, laxative use, again, rigorous exercise, and then also the binge eating compensatory behaviors both occur on average at least once a week for 3 months. Um, it gives you a range as to what those behaviors look like, the intensity, and then also you know um, the level of how often the person might be engaging in these types of behaviors. So some of the common signs, if you're suspecting someone is struggling with bulimia, there could be a disappearance of large amounts of food, empty containers, wrappers. This person might spend a lot of time covering up the binge rituals and dispose of the evidence, so to speak, of the binge. Frequent trips to the bathroom after eating to vomit, you might smell vomit, or the presence of laxative use. This person also might drink excess amounts of water or non caloric beverages. To the severest degree, they might have calluses on the back of their hands or knuckles from trying to induce vomiting. And there also might be some dental problems that will just progressively get worse down the line if there's a constant behavior of purging present. So, some of the risks and complications that go along with bulimia nervosa: elevated suicide risk. Um, there is a diminished gag reflex and difficulty swallowing because you are, ultimately causing a lot of damage in this area. There's also a lot of gastrointestinal complications, um, possible infertility, dental complications, like I just mentioned, and then other types of physical issues or medical issues, such as chronic dehydration, electrolyte imbalance, pancreatitis, and also cardiac arrhythmias. So those are just some of the risks and complications. I'm not going to go over all of them, but they're just know that eating disorders, out of the entire book to diagnose mental health disorders, eating disorders has the highest mortality rate. That is next to the opioid epidemic. I think the opioid epidemic might have surpassed eating disorders, but I do look at that just a tad bit differently, only because this eating disorders, um, each diagnosis, whether it's drug and alcohol or eating disorders, it's very complicated. So with eating disorders, again, one of the highest mortality rates. The next one is binge eating disorder. Again, there are recurrent episodes of binging, which is defined by eating in a short period of time larger amounts of food that others might not eat in a quick period of time. There's also, again, the sense of lack of control over the overeating. And then what is different about binge eating is that there's no compensatory behavior to get rid of the food or to burn calories. Instead, there are other different symptoms that would go along with getting the diagnosis of binge eating, which are the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feeling embarrassed or how much one is eating, feeling disgusted with oneself, depressed, or very guilty afterwards. And there are also, in order to get this diagnosis, there has to be a marked distress regarding the binge eating when it's present. And again, they give you a timeline of what this looks like in how often the symptoms would occur. And again, it's similar to bulimia. The binge eating occurs on average once a week for 3 months. So some of the common signs to look for if you're suspecting someone might be struggling with binge eating disorder: Steals or hoards food in strange places, creates lifestyles or schedules or rituals to make time for binge sessions. There could be disappearance of large amounts of food or empty containers or wrappers, once again, and then also can spend a lot of time covering up the binge rituals and disposal of the evidence of the binge. Some of the risks and complications to binge eating. Gaining weight up to upwards of obesity, even morbid obesity, depending. High blood pressure, high cholesterol, heart disease, possible type 2 diabetes, maybe gallbladder disease. So again, it not only affects the mental health, but it affects the physical health as well, no matter if it's anorexia, bulimia, or binge eating. So moving on, like I had said before, these are what I call sort of the honorable mentions. These are not actually in the DSM, the book that we use to diagnose mental health disorders, but they are growing in popularity as far as the words that we use to describe the disordered eating that someone might be struggling with. So one of the ones that has been used very frequently is orthorexia. So it's an obsession of eating only the healthiest foods possible and avoiding foods that one feels are harmful. So this might look like only eating like vegetables, grilled chicken, and rice every night. Some things, foods that that person only views as healthy. And it might look normal, but what happens with orthorexia is they slowly start to decrease the amount of variety that they might have in their diet or in their eating repertoire, because they might start to fear things might be unhealthy. So it could lead to restriction. There's diabulimia, so the manipulation by diabetic patients of their insulin treatments in order to lose weight. Compulsive overeating, it is a little different than binge eating. Rather than having episodes of binging, the client takes in large amounts of food all day long. I also include in here body dysmorphic disorder. This is a persistent and intrusive preoccupation with an imagined or slight defect in one's appearance. So if, let's say, you men out there that like to lift weights, which is great to be healthy. But again, if there's any sort of type of disordered thinking happening around your body, you might not think that your muscles are big enough or your abs are, apparent, that sort of thing. And so there's this obsession that starts to create around that specific body part that could lead down the road to affect what you eat and affect your behavior, excuse me, centered around what you view as a defect. One other one that I want to mention that is in the DSM is atypical anorexia. Atypical anorexia is what you're actually going to see. It's most common. The reason why I say that is in anorexia nervosa, one thinks that that person looks like they are significantly underweight, and they are more often than not. But then you have atypical anorexia, where they are restricting and they have the intense fear of weight gain, but they are on what's considered a normal body weight, or they're within their normal weight range, but all the symptoms are present. This one is a little bit trickier to, point out if you're in a doctor's office, but at the same time, it's something to keep your eyes open to, because it does lead to severe complications down the road, sort of with up and down weight gain possibly, which puts a lot of stress on the body. So that is sort of one of those ones that I want to mention as well. So what causes an eating disorder? Well, I could probably talk about that for days, but with that being said, I've boiled it down to what I consider and call the perfect storm. What I mean by that is we look at it from a biopsychosocial model. Usually, more often than not, there's a genetic component. Just a little bit of a statistic, 50 to 80% of the risk for anorexia is genetic. Again, really high percentage. Um, there's also possible history of dieting or weight control tactics. This is where maybe, in the family unit, there was a lot of attention paid to diet culture, body image, that sort of thing. And there's just been this on again, off again history of dieting. And that sort of could lead to disordered eating down the road. Um, and then also type 1 diabetes. That also could spring into action and eating disorder, whether it be bulimia or anorexia or binge eating. The psychological part, like perfectionism, body image dissatisfaction. Sometimes people who struggle with eating disorders also struggle with bouts of anxiety or persistent anxiety, and trauma. Trauma is a huge one that we definitely address here at White Pine Center. We usually do a lot of trauma treatment just because in our experiences here, more often than not, someone coming through our doors that are struggling with disordered eating, they have trauma in their history, or they might be living through it currently. An eating disorder is a way to cope with that trauma, or with childhood family dynamics, or whatever the case may be. And so that's why we take such a close look and care for that trauma and treat it. And then the social part, weight stigma, teasing, bullying, appearance ideal. Think about how many images we are inundated with on a daily basis through social media, magazines, TV, celebrities. And so when you're inundated with those messages, especially in our youth, even down to our elementary kids, like the couple statistics I mentioned earlier, this really can weigh on someone, especially if they have some other factors like perfectionism, or I just really don't like this part of my body. This is why I call it the perfect storm. You gather all these factors, and boom, the eating disorder sort of can come in and hijack the brain. Um, so some of the things to just think about, if you are tuning in and you think, hey, I have some of these things, I like to sort of help people come to awareness as to, how their eating disorder formed. Because once we build that awareness and, truly understand ourselves and how we're coping via the eating disorder, that leads to some breakthroughs in treatment. So some things that I do want to mention as well that could be a part of the perfect storm is there's definitely a relational element involved. What I mean by this is that the eating disorder is the secondary issue. It is not primary, although it can feel like it, especially if someone's at the lower end of their weight range considered, in anorexia. The primary problem is first, which usually presents as unhealthy family dynamics or attachment wounds. The eating disorder becomes the main relationship to the client, and a lot of the time mimics or reinforces that unhealthy relationship pattern or the trauma. And so you can see just through that little bit that this could become a vicious cycle, which is very difficult to break out of. Eating disorders can be very difficult to treat, but not impossible. And the earlier we catch it with our youth, our adolescents, the better trajectory they have towards health and really trying to heal through the disordered eating. So nourishing the body and the brain is important, as well as nurturing a healthy relationship with yourself and with others. So we want to surround ourselves with positive supports and a healthy environment so that we can thrive rather than sort of getting back into those negative cycles and feeling like we need the eating disorder in order to survive. Another thing that I think is important when just sort of looking at the basics of what an eating disorder is that eating disorder, you have to look at it as a separate entity from the client. So it sort of takes on its own identity, and it's what I've used the terms before, it hijacks the brain. I find this helpful to remind families of sort of what this phenomena is. Once a client has engaged in an eating disorder for a decent amount of time, We have to look at them as separate. So, again, the client and then the eating disorder. And we're really trying to separate how intertwined that relationship can be so that we strengthen the client's own identity to the point where they don't need the eating disorder. And just a little tidbit for parents out there, do not ride the wave of emotion caused by the eating disorder. So if you have a young child at home or an adolescent at home that's refusing to eat and they don't want to eat what's on their plate and they're really giving you a hard time, like let's say at dinner, it's very easy to get angry and to have tensions really escalate within the household because of this fight. And it's understandable because parents, I know you're fearing your child, getting worse and worse, and it is frustrating. But one of the things that we really do in family therapy here is we really try to help the family take a step back, realize it's not their child, it's the hijacked brain sort of taking over, and don't ride those waves of emotion that you see your child exhibiting. And we give tips and tricks for that as well, just to help the overall family dynamic. And one last thing, which I think is important to mention, is that depending on the chronicity of the illness, it can be looked at as a long, slow suicide, conscious or unconscious. And I know that's a very strong language to use, but in my time of working with eating disorders, which has been a decent amount of time in the field since 2007, um, when you have someone that has struggled for years and years, especially more in the anorexic, category, if you will, but it definitely happens with bulimia and binge eating, it can feel like the hopelessness just gets bigger and bigger, and it can really take on the feel of a slow suicide. And I feel that's important to mention because I want our medical community to truly understand that the severity of this illness, and that it can take on a lot of different whys, like why that person is engaging. And one of those whys might be, I don't want to be here anymore, and this is the best way that I found to not feel and to not be here anymore. So it's scary and it's a hard topic to talk about, but that is our mission here, is that we need to talk about it. We need to talk about these hard things centered around disordered eating. So a couple more points during our lunch and learn. When we're looking at eating disorders, we definitely want to approach it from a multidisciplinary approach, meaning the treatment of a client should not just fall on the shoulders of a therapist or the dietitian or a PCP or a psychiatrist. We want to bring all of these clinicians together and build a treatment team to help support that client who's in need. And so, for any clinicians that might be tuning in and listening, I don't want you to think that you're in this boat alone. If you have a client that's come in that is really struggling with a severe eating disorder, as a therapist, we want to help support every single person that is on the treatment team, because there's always the nutritional component. There's definitely the mental health component, and there's definitely the physical and medical component, let alone prescribing, medications that could help build a bridge to make it just a little bit easier for the client. Excuse me. So, a couple more things. What do we do for eating disorder treatment would probably be a question for some. We, at least here at White Pine, we use a lot of evidence-based therapy to treat the eating disorders, as well as other modalities and other wellness practices to just sort of give them a holistic approach to therapy. So, yes, we are using cognitive behavioral therapy, one of the most popular ones out there, dialectical behavioral therapy, ACT, acceptance and commitment therapy, definitely family systems therapy. We also do heart math here at White Pine Center, and we also do EMDR, which is eye movement desensitization and reprocessing. EMDR is used primarily to treat the trauma. And it's so far, at least in our practices, it's proved to be, pretty moving within the therapeutic relationship and getting that client unstuck in some areas. Some other things that I, like to mention are internal family systems and psychodynamic therapy or psychotherapy. So, and interpersonal psychotherapy, IPT. Those are some of the ones that I know I use and I know the therapists use here at White Pine. And just I would like to quickly go over the different categories of levels of care. If we're looking at eating disorders 101 or just general outline of what they are and how we treat, I think this is an important component. So at the highest level is inpatient residential. This is where you're going to live at the facility and sort of be really immersed in that treatment environment. The next is a partial or day program. It's a step down. You're not spending the night in this program, but you are there pretty much all day, making sure that you have your meals and you're in group therapy. There might be one-on-one therapy as well. Family therapy is also included in both of those levels of care. And the next level down is in IOP, which is intensive outpatient. What that means is 3 hours a day, 3 days a week. So you can see the level of care is stepping down as the person, your client gets better. Excuse me. Then they can step down and step down into sort of a less severe form of treatment, I guess, until the very last stage, which is outpatient, which is commonly known as just one-on-one with a therapist on a weekly basis or bi-weekly basis, depending on how well that client is doing and how much support they may need. And with this ladder, in a way, you can either travel up. So let's say someone is starting to, take some step backwards in their health. Then we can offer, a recommendation for a high level of care so that they don't get they don't take too many steps backwards. And we make sure that we treat that pretty quickly so that the eating disorder doesn't come back with a vengeance. The way I like to think about eating disorders, it's a volume dial. And the whole point of therapy and, working with your treatment team is to really turn that volume down of that separate entity that exists within the client, within the brain. But if life happens and that dial might get turned up a few ticks, and so we have to pay attention to that and make sure that we're offering levels of care that are necessary in order to keep that client stabilized and living a healthy lifestyle. So I think that's all that I can think of as far as eating disorders 101, sort of going over the very basics of what eating disorders are, sort of how we look at them, how they're caused, how we treat them, very brief in how we treat them. And but if you have any questions, please put them in the questions box, depending on what platform you are watching this on, and we'd be happy to get back to you. Again, thank you so much for tuning in. I'm Brandis, the clinical director here at White Pine, and thank you for stopping and engaging in this conversation because our Erie community and surrounding communities need it. So have a good day and enjoy your lunch. Bye.